Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all. Hello, listeners, and welcome back to the show. Today, I'm chatting with Tanay Tandon, the founder and CEO of Commure, a platform that combines software, hardware, and AI to simplify and humanize healthcare. Tanay, welcome to the show.
Thanks so much for having me.
So Commure is the product of a roll-up of Commure and Athelis that went on to then acquire Augmedix, RX Health, and Memora Health. So really this group of a bunch of companies kind of coming together, and you guys have raised over $750 million. So when you zoom out, what is the big idea behind Commure today, and what is it that you're ultimately trying to build?
I think the core thesis of Commure from inception all the way to today is, can we build software that actually makes physicians' lives easier, saves them time day to day, and in general makes hospitals run more efficiently? I think there hasn't been a great software business that is truly provider first. We've seen amazing EMR businesses that are built for the CIO's office or the CFO's office or compliance's office. But I think a software company for physicians, almost built in some ways by physicians or hand in hand with physicians, was the goal of Commure.
Okay. And why the roll-ups and acquisitions to do this versus building it organically?
Well, I think we've built a lot of stuff organically, and we've used M&A as a tool for both distribution and certain features and capabilities that would just be faster to bring onto the platform than have to build de novo. I think a good example of that is when Commure and Athelis came together. Athelis, which is the company that I founded, had a whole host of revenue cycle tools and practice management tools that were geared towards the mid-market. And these were tools that Commure could build on its own, but it would take years and years and years. And we share this amazing investor in General Catalyst and Heyman, and sort of brought the company together with this shared vision. And so speed is one reason. And then I think in general, M&A is a very underutilized weapon by technology companies. If you look at some of the greatest companies ever built in American history, that's like Rockefeller, Standard Oil, General Electric, Genentech, Meta. These companies were built on the backs of great M&A. That was really the core.
Google,
Google. I mean,
Yeah.
and so in my opinion, I think healthcare in particular hasn't used M&A as effectively as it can from a software standpoint. And that was part of our bet.
Yeah. Investors love M&A, right? It's just more opportunities for companies to find homes where they can fit and grow. So you guys recently received $200 million in growth financing from, as you mentioned, GC, but it's through their Customer Value Fund, which is a new model of funding where GC has pre-funded your sales and marketing budget, and they're paid back by a cap share of the cohort of customers acquired. Or if the spend does not pan out, GC owns the downside. This is a really interesting new instrument. Talk us through kind of choosing to go this route versus taking on more equity.
I think the beauty of CVF as an instrument is it works amazingly well for businesses that have recurring, predictable growth, where if you put $1 into your sales and marketing, you get $3 or $4 out, and you can do that again and again in a very large market. And I think to some extent, growth financing has, in the kind of traditional growth capital world, has been morphed into this monster that was created in the last 5-10 years of VC, where you have these mega multi-billion-dollar rounds and multi-$100 million rounds again and again. And that's not how companies used to operate. If you study Google raised $25 million total in its entire history. And then after that, it used its customer revenues in order to fund growth. And so our bet here in using CVF was, one, let's avoid dilution for the current investors. We have a predictable growth model. We do want to accelerate. And so let's pull forward from some of that cash, which is effectively future customer revenues, and put that towards growing the sales and marketing effort, and take S&M costs off balance sheet and focus our balance sheet on R&D and long-term investments. And I think the other thing that it does is it forces you to mature as a finance org and as a sales and marketing org, because you have to have that degree of predictability in order to access CVF as an instrument. And you can't just pull it for an unproven go-to-market motion.
Yeah. It makes more sense for a later stage company. It'd be a little harder for a company trying to still work on their MVP or, find product market fit. It might not make sense, but you guys have already kind of built out a product and you've already been selling, so it is more predictable. Tell me about something you thought would be easy about building for hospitals that actually turned out to be extremely hard.
I thought that you would show up and you would put software in the hands of a doctor and confetti would appear from the sky and everyone would be super happy. And the same software would work again and again for every hospital and every physician and every specialty. And what the reality of the situation is that every physician practices so differently and every specialty practices so differently and every health system is set up so differently, from an IT stack, from how they run their operation and their innate operating model. And so what we learned is that configurability and this concept of forward deployed engineering, which Palantir has used so well, and we've sort of taken leaf out of their book, is you got to get engineers on the ground. You got to be able to customize and co-develop with the health system and adapt your software for the needs of that given department that you're working with. And this is counter to probably decades of traditional enterprise software wisdom, which is build a cookie cutter thing and then just give it to everyone very quickly. And I kind of like this about healthcare because, one, there's an inbuilt moat. Every system that we deploy at, because of that degree of partnership and configuration, there's time that we've spent, and you go a little slower at the beginning, but then in the long term, I think it compounds. And you look at our partnership with HCA, for the first couple of months, it was literally 3 physicians that we were just working very closely with. And then it grew exponentially the minute we had it working for that group of 3 to the point where we signed the enterprise-wide agreement to take it to all 186 hospitals that HCA owns.
Wow. And then who pays for that upfront, all that upfront development? Is that something that you co-develop with each hospital? Do they pay for that time, or are you kind of taking a risk and building it out, hoping that there's a longer contract ahead?
In Commure's case, we take on that risk, and we're lucky in that we're well financed and well backed that we can take on that risk. I think even for smaller companies, this can be a workable model. You just have to really focus on your iteration cycles and be super scrappy. I think in the early days of when we started the company, the forward deployed engineers were me and Deepika, my co-founder, or me and Drew, our CTO. And there's not a lot of leeway to get it wrong when you're doing something that custom in a health system.
A lot of founders early on get stuck when it comes to selling to hospitals because they get put into pilot mode and they're working with a team that is really passionate about bringing new software into the hospital, but not necessarily able to sign big checks.
Yeah.
Who is it that that a founder needs to be talking to and partnering?
I think this is the core problem in healthcare enterprise sales. And we have found a couple different solutions to this problem. Number one is whether it's not the perfect answer, but you have to start off with the expectation that it's going to take a long time. And even if a physician, someone in the back office is seeing value, it doesn't mean you're going to have a contract in hand the next month. You both have to.
How long can you quantify long time?
I think before you have real dollars committed to something, you need visible people in the system seeing value for like 6 months. And that's kind of what we found, where they need to be saying good things about the software. They need to be evangelizing it to their peers. And the other learning that we've had is, as a company, we've actually more and more come to focus on the for-profit segment, not because the academics or nonprofits are not a compelling market. It's just that the for-profits are sometimes run more rigorously in that you have centralized decision making. In nonprofits and academics, you often have this tragedy of commons where no one wants to pull the trigger and say, we're doing this. And I think the defining characteristic of well-run organizations is that they often are quite top-heavy. You have a small group of people who can make calls and take bets. And if you don't have that, the organizations tend to evolve very slowly, tend not to be good partners.
And what about overcoming the switchover disruption that a lot of these providers face, where they're moving to a new software and there's going to be some sort of disruption in terms of training staff on it, just new procedures? just doing things differently and facing the inevitable tension that arises when you're asking people to do their jobs differently.
I think with LLMs, there is, for the first time, this de novo opportunity where there might not be a software solution that's in place today. And you look at something like ambient documentation, that literally was a person's time, or, you know, a medical scribe that was sitting in the room that is now software. And because of that, the adoption curves have been very quick relative to, call it, traditional one-for-one software replacements. Yeah. With that being said, there's still the same concept of a switchover, and that someone is having to change their workflow, they've, you know, change how they run their day. And what we have found is you just have to be super upfront about that, and you have to be super prescriptive in terms of, this is what the migration is going to look like. This is what implementation is going to be like. Let's get concurrence. It's going to be a sticky process, but at the end of it, there's this proven ROI that we're all fighting for, and it will come. So I think over communicating and overriding is the only real solution.
Yeah. I mean, the biggest expense in healthcare, especially at hospitals, it's really the people, and it's really expensive to employ healthcare providers and administrators. So it's no surprise that a lot of the AI tools we're seeing today are what we hear called the copilot tools, and they enable folks that are in the seats today to do more. But when and where do we move to the autopilot tools where AI is actually doing the job, because we are facing a shortage and insanely high costs of care?
I think it's starting to happen already. One example from Commure has a large revenue cycle operation and revenue cycle product line, which is meant to automate a lot of the tasks that are traditionally done by a back office. So one metric I always like to tell people is we 5x the volume of claims that are going through our system in the trailing, call it like 12 months. And in that same period of time, we kept the number of staff steady. And so that means your denial staff, your AR, et cetera, it stayed, you know, this operations team stayed flat. And that was only possible because we had agents and LLMs that were doing these tasks that were traditionally humans sitting around, clicking on a dashboard, calling up an insurance company. And so that world exists today. It's just, you know, not evenly distributed, in that not every health system has adopted these tools. And as a result, they're leaving margin on the table. I think in the world of physicians, I'm actually less bullish on full-blown autopilots for clinical decision-making. I think you really want to assist the clinician and give him or her superpowers, as opposed to try to, you know, replace parts of their decision-making. I think just from a care delivery standpoint, humans at the end of the day want another human that has reviewed their case and assessed it holistically, something that a language model still can't do, given just the number of inputs that are coming into that.
Yeah. I mean, I don't know if we're going to be able to stop people from going to ChatGPT the way they've been going to Google to solve all of their questions. But in terms of AI being used as a enabler for people to do more work, you can say that, but I do think that providers still fear being replaced. We saw the nurses at Kaiser protesting just last year, the use of AI. How do you overcome just like the fear? Like, you can say this has helped you do your job better, but in the back of their head, I think all of us are like, have fear of AI taking our jobs from us and our livelihoods.
Well, one of the, you know, analogies that we talk a lot about is the last time automation was really brought to the States in a meaningful way, you know, it devastated our auto industry. Like tens, if not hundreds of thousands of jobs just got sent overseas or turned into machinery that was running in China. And we can't make that same mistake again. I think it is a very real risk. And I think the way to do it is you have to pair upskilling of the labor force to actually use these tools, while at the same time adopting them quickly so we don't fall behind as a nation and as a healthcare system. For me, the most important thing is the most important stat is if we were in a case where healthcare providers were not burnt out and were having a great time doing their jobs, then yes, there's an argument to be made like, okay, well, let's slow down the adoption of AI and really think about it. But we're not in that world. You know, the supply does not meet the demand of healthcare. And as a result, we almost have no option but to take parts of the day-to-day of a nurse or a physician and start to use LLMs to support it. Otherwise, we're just going to fall behind.
So what do you say? What do you say to like the nurse that's listening, that's totally afraid of AI and wants nothing to do with it?
Yeah. My personal belief as a optimist, a techno optimist, is every time that software copilots or automations have been brought into legacy industries, there is an opportunity for more job creation. In the automaker example that I talked about, there was net new job growth. It just happened in China because we didn't build that automation infrastructure here. And if you look at the finance industry, when ATMs were created, this is a commonly used example. ATM showed up. We thought we would lose bank tellers. The number of bank tellers 10x'd because, again, when you have this supply-demand inefficiency, the minute you make it easier to access a service, you have more people that show up for it, and as a result, there's auxiliary work that's created that probably only humans can do. So what I say is that one, if we don't embrace it as a country or as a health system, then we're going to start seeing these pop up AI, 100% AI telehealth systems, or basically a health system that adopts AI will outcompete on a margin standpoint and a quality of life standpoint for its physicians, a health system that does not use AI. And that's the real risk because it's coming. It's here. People are adopting it every single day, and it's better to embrace it than try to hide from it.
And so how do we upskill folks that are working in healthcare that maybe they've come around, they're listening to this podcast, they heard your argument, they're like, okay, fine. What can they do to actually get upskilled and make sure that they're prepared for the future in healthcare, of working in healthcare?
The beauty of LLMs is that they can be delegated to very similarly to humans. But it requires a new form of thinking in terms of how you interact with a computer, in that instead of clicks and prescriptive sequences that you might ask a computer to do, they can synthesize information. Deep research can take hundreds of sources of information and turn that into a very clean report that aids with decision making. My recommendation is to literally just play around with these LLMs, whether it's an ambient AI tool and you get into the settings and play with the prompting and try to experiment with, well, how much more can I have it generate for me? Can it do the referral document, the intake document? And we make the prompts very accessible to users and allow them to play with the ambient intelligence within our application. Even just popping open ChatGPT and seeing how much of your day-to-day you can turn into a set of prompts, I think is a really good exercise. Yeah. And so the people that embrace that new form of thinking, where I want to actually have asynchronous tasks given to a computer, have them running alongside my own decision-making, I think will do well in the long term.
So when AI does take on more responsibility in healthcare, how do you think about drawing the line between like automation and accountability and thinking about who's responsible when and if AI makes a bad call?
So I think AI in many ways is going to be a gift when it comes to traditional malpractice suits and traditional litigation and liability as it resides with health systems and providers today. And the reason for that is, imagine having an expert in every room and every conversation at every point of time that you can point to as both, a tool that helped come to your decision, but also defend it. And so if you look at the field of computer science and when you write software, the accountability and traceability to when a decision made is immense, because there's logs and there's audit trails that are created with every little thing that you do. And if you're a well-intentioned actor, if you're an engineer within a company that is trying to build a good product for a consumer, if there's a bug or something breaks down that causes issues out in the field, you always have that quick traceability. And as a result, the intent, you don't hear about software engineers getting sued for malpractice. And the reason for that, I think, is because the audit trails are so profound and so clear that intent becomes very clear. If you have malicious actors, it's a different story, and they get prosecuted and you have liabilities assigned accordingly. I think in healthcare, you don't have that, where intent and competence are often disambiguated, and LLMs there's a real opportunity where with an LLM, if it's in the room and it's guiding the physician and bringing in all the relevant information, it becomes that backstop. And I think at the end of the day, you still want, as a patient, to have someone you can hold accountable as a person that made the final call. But the supporting documentation that LLMs produce will be a gift to providers.
Yeah. So stepping back, in your career at Commure, you've had some real highs, but you've also had some tough moments along the way. There have been some disputes and some critical coverage in the press. When you look kind of back at some of these things that you face and the company has faced, what are kind of your biggest learnings that you would share with our audience?
I think the defining characteristic of whether a company succeeds or not is grit. That's really, when you study Pixar, when you study Apple, when you study these great businesses, these are multi-decade long battles. And we're at an interesting point of time where the tech press in particular often likes to pick on tech companies, which is interesting.
You're not even a female founder.
That's really crazy. It seems like there's like a totally unfair article almost every week towards a female founder in some way. And I think what I've learned is it's just noise. And if the things that matter are happy customers, expanding customers, a team that is well-intentioned and willing to do hard work. And if you do that month over month, week over week, you win. And there have been quarters where things have been really, really hard, but those are the quarters that made the business what it is today. And I think the degree of compounding and the degree of scale that we've developed as a machine and as a combined entity now would not be possible without those tough moments. I mean, we started as a medical device diagnostics company at Athelos. That's like, what I started. And it took 3 or 4 years of iteration to really develop what is this software platform now that we're distributing.
Yeah. So last month, specifically, you had to stop selling one of your products, which was the hospital panic buttons. Can you tell us about what happened there and your side of the story?
Yeah, it's a complicated situation because one, we actually just settled it, which is great. Strongline is back on the market. We're repartnered with the vendor that we had the dispute with. This was a legacy vendor, Canopy, who Commure had worked with actually before Commure and Athelos merged, and we took over Commure. And they wanted to go at the market on their own. We wanted to go at the market on our own. These disputes happen. I mean, I think litigation and IP is at the heart of American capitalism. Thankfully, we're now in a situation where both companies came to terms pretty quickly around a solution that we're happy with. And the most important thing, I think, both in the course of the last couple months with the Strongline situation, as well as in the settlement, was just making sure that patients and providers were protected. At no point of time did a single Strongline badge go offline. We worked together to ensure that the system was always up. We were able to continue to support all our hospitals, the 200,000 plus nurses that use the platform. And I think when you have that North Star, you can always get past a lot of these problems.
What is the product? So you said Strongline, it's a panic button, but what exactly is it?
Yeah, so Strongline is a really simple solution. I mean, it uses BLE, Bluetooth Low Energy, in order to help pinpoint where staff is in a hospital. And when a nurse, nurses are often the subject of workplace violence at much higher rates than almost any other profession in the world, because they're dealing with patients from all walks of life. Some of them have mental health issues. Some of them are, just not in a happy state. You have fights break out in hospitals. That nurse, he or she can double tap the button and it indicates that there's a duress situation. It notifies security. It also notifies other nurses around them, converge on the situation and de-escalate it very quickly. So really simple product, but I think one that is one of our most loved products because nurses have come to rely on it so much and security teams have come to rely on it so much in hospitals.
What are some other big lessons that you've taken away?
When we started the business, I always believed that, you have to have this insane vision in order to build this complex technology platform and, need to be a platform company from the get-go and be very strategic. And I think I've come to realize that often the hardest thing is just adding value to one provider. Like get on the ground, sit in front of the physician, write up some software that makes their life a little bit easier. And that is a surprisingly challenging task. And the number of healthcare companies that I see working in a bit of a vacuum where they're sitting in their, Silicon Valley offices writing code, hoping that it will be useful for a physician. It's kind of, that's how we started, and it's a huge mistake. You should get in the practice, even if it's a small private practice that, lets you tag along for the day. You will learn more from doing that than, months and months of whiteboarding. And so for us, we have this deep forward deployed culture where our sales teams, our engineers, our operations teams, they live and breathe the hospital. They stay on site as long as they can, and they fine tune their tools in a way that actually makes the provider's life easier rather than just trying to theorize about it.
It actually sounds a lot like Epic's approach, right? Like they have massive teams of developers on the ground. Speaking of just selling into the hospital, I want to hear what you think it's going to look like in 10 years, because even just today versus 10 years ago, the rate of adoption we're seeing is so much faster.
I think the hospital and health system of the future is going to look more and more, hopefully, like auto insurance or how we maintain our cars, and that you have this concept of catastrophic care when you break an arm or you have a very complex disease. And then you have this concept of more recurring preventative care that you actually just do from the home. And it's a range of software and sensors that are helping monitor these patients and chronically take care of them, with data streams flowing continuously into a physician's dashboard. And so I think hospitals in particular, you're going to see them, internally we like to call it like the return to the 90s, almost like, in the 90s, I feel like the lives of physicians were great. Like you had time to spend with almost all of your physicians, with all of your patient panel. You had, you were in a situation where you could really specialize in your craft. The documentation burdens were emerging, but not really cumbersome. Digitization hadn't yet come with its full force. Insurance companies were less of a factor. It was a simpler system in many ways. And then this complexity emerged, and the lives of doctors became just so, encumbered with whether it was documentation, insurance compliance, et cetera. And so I think LLMs are taking that out. And you're going to see a simpler hospital that is more focused on care. Everything from the kiosks and intake to what happens post-visit and pre-visit. It's going to be software and LLMs that are running. And then the heart of a health system will be really its engine, which is a physician taking care of a patient, treating that patient. And I think hospitals become higher margin. I think we can revert to an era where hospitals are 10, 20% margin businesses, which is good for everyone, because that means that we'll hopefully take that margin away from payers and bring that to the site of care.
What about consolidation? Do you see that continuing, or do you think we'll go back to having more independent regional hospitals?
I actually believe in a more decentralized, independent world. And the reason is that much of the cause, or much of the inputs into centralization and consolidation, were the operational complexities and compliance complexities of running your own practice or running a hospital. And with LLMs, those are going away in terms of filling out forms, sending in documentation, dealing with audits. A lot of that busy work is turning into something that one person with an LLM can do and kind of manage on their own. And I think more independent hospitals is net good, because one, it means more competition. And then number two, it means you have more localized, specialized care, and you have more small businesses or medium-sized businesses in the country, which is the heart of the American economy. We
have, I believe, 1 million hospital beds across the U.S. today. Does that number stay the same, or does that number shrink with the future, your vision?
It's interesting. I think, there's like inputs in both directions, in that my hunch is that number itself stays like somewhat flat, and then you have more of just to meet the growing demand. And then you have excess demand that flows into care from the home, whether that's hospital at home, more chronic care, more preventative care, and hopefully your transition of your excess capacity or your forward-looking excess capacity into lower acuity sites of care that are just cheaper to tend to.
Yeah. So you said you're a techno optimist, and you obviously think a lot about AI beyond healthcare. AI is going to change our lives in a lot of ways that I think we don't even know. But what is your take on how AI could possibly change lives of Americans in ways that will indirectly impact healthcare?
I think as a techno-optimist, my belief is that there will be more jobs in the future. I think they're just going to look different, in that you're going to have more independent filmmakers. You're going to have more independent software engineers that are running like 10-person companies. You're going to have, again, like more small practices, more physician-owned practices, and all of these are net good things. And so I think one of the side effects or outputs of AI is more businesses, because in general, you're just going to have more autonomy and agency for people to do a lot more tasks every single day, and as a result, keep more of those profits for themselves. The other, I think, is the world will change. You will see, I think, your average person just have more spending power effectively, in that they will be able to spend more on the consumerization of healthcare, whether that's cosmetic, whether that's preventative. You see like this boom of supplements and a lot of these online kind of care plans, I think that will continue and that is usually a function of excess income appearing in society. Like people have money to now spend on things beyond their core needs of housing, internet, food. And so which will I think be a good side effect, in that a lot of your spend that traditionally appears later in the system in chronic disease will probably be handled for more upfront and out of pocket by consumers because they're willing to just put in that investment upfront, which hopefully results in lowered insurance premiums or a smaller role for insurance companies to play in our lives, which I think is also a good thing.
Wow. So you see a prosperous future for everyone. Do you have any concerns? Like, what's the worst case scenario?
I mean, the worst case scenario is obviously the whole, like, Rocco's basilisk, the AI goes crazy and we're all its slaves. I think that assumes the AI has biological intentions or biological like core drivers. And I think we control it, and yes, it can evolve and it can self-learn and all these things, but I don't know, it's hard for me to visualize a world where there isn't an off switch. and
just like unplug it. That's what I always wonder.
But who knows?
Just unplug it.
Yeah, just unplug it.
Yeah. I feel you. I go back and forth because I do feel like a lot of roles are going to be made redundant or, unnecessary. And so I worry a lot about ripping out a lot of middle-class jobs, just like we did in the 90s,
Sure.
when manufacturing left. I do worry about that.
I feel like the automation analogy, again, globally more jobs were created. Like capitalism won in some ways in the offshoring of automation or the offshoring of automotive manufacturing. And I think if we had just built that automation infrastructure here, we would have retained those jobs. And it was a flaw, like a policy flaw that we didn't.
Well, any last words that you have for our listeners today?
I think it is a really exciting time to build in healthcare, and we're going to see a lot more businesses created serving providers, which is a good thing. I also think that one of our learnings from Palantir is that the hardest challenge in almost any legacy industry is distribution. And so my pitch to folks is that the Commure in particular is a pretty cool place to work on these problems. And obviously I'm self-interested in saying this, but it's if you find a vessel that has distribution and you're a hacker and you want to just come build, we're I think a great home to do that. And there's a lot of great homes to do that. Palantir is one of them. I think there's just sea of companies that are getting created now that have distribution, have problems, and need smart people to come work on them.
Awesome. All right, Tanay, it was great chatting with you. Thanks for being here.
Thanks so much.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.
In the time it takes you to actually board a flight from Group 8,
Now boarding Premier Altitude Elite Club members.
you could have bought a Hyundai on Amazon. Visit HyundaiUSA.com or call 562-314-4603 for more details. Limited availability, pickup through participating Hyundai dealer in select markets.